practice in Bozeman is an internist. Don't you do
Geriatrics.
Geriatrics only now.
Pretty much, yeah.
Yeah.
Geriatrics and palliative care.
Yeah. Which is where the fun stuff is.
That is where the fun stuff is. I have some compatriots who would not agree with that, but let me tell you, that is the fun stuff.
So she's going to tell us a little bit more on the POLST and also maybe fill us in on a little bit more of advanced care planning, which, as we all know, is extremely important for all of us. So take it away.
Thank you, Lottie. Appreciate it. So I'm curious. I know everybody in the room are nurses. Yes? No? Okay, great. Who else is in the room? Social workers. Terrific. Others? Okay, and how many of you work in the hospital? Okay, how many of you work in assisted living? How many of you work in nursing homes? Wow, and what am I missing? Oh, outpatient settings? Who am I missing? Home care. Oh, home care. I forgot hospice. Hospice. Home care. How could I forget hospice? What I want to talk to, and how many of you are familiar with the POLST? How many of you are using it? Okay. So one of the things I'd like to find out from you guys at some point are issues that you're having with them, and hopefully I will be addressing some of them. But I want to give you a framework first about the POLST so that you have some understanding of what it is. And please ask questions. You can interrupt me if I'm not being clear. I'd be really happy to hear about things. So one of the problems with advanced care planning in general is how many of you know what you are going to have for dinner next Thursday night? Okay, one of us. So I think I know what I'm having for dinner tonight, although I may be going out and then I really don't know what I'm having. So in terms of how we think about things, we may not know whether we want a breathing machine 1, 2, or 10 years from now. So asking that question, do you want to be resuscitated, has to be in a context. And that may not be the first question you want to ask, and I'll talk about that. So I want to tell you about 2 people and have you think about this as we're going through this presentation. So the first guy is a patient that I see not infrequently. He's 85 years old. He's got severe heart disease, heart failure, COPD. He uses oxygen. He's had a stroke. He's got left-sided weakness. He's dependent in most of his ADLs. And guess what? He's also got pancreatic cancer, and he's been in the hospital 4 times, and he's been in a year, including being intubated in the ICU. So I'm going to have a very different conversation with him than I'm going to have with this guy. 85-year-old guy, same age, hypertension, hyperlipidemia, just got back from a cruise. What he's really interested in is, when am I taking my next cruise, and why should I care about this, and how am I supposed to know what the hell is going to happen to me? So what I want to talk to you a little bit about is what we as providers can do. How do we create a process that will help these patients, these individual patients, and facilitate their goals, and then what tools are available, including the POLST, which is just one tool that you can use. The bottom line, though, is that no form or checkbox was ever going to eliminate having a conversation. We have people who come into the hospital, they come into hospice, they come into the nursing home, they come into assisted living, and even though they have this document, the POLST document, I have to sit down and go over that conversation with them again. And I would say to you that every time somebody's disease state changes, you need to go through it with them. Those of you who work in nursing homes know about the MDS, change of condition, okay, which is defined in a lot of different ways. You have to go through a whole new assessment. And I would say that this has to be part of your assessment. There are some problems with the idea of advanced care planning. Okay? So when I mean advanced care planning, I mean advanced directives and ultimately the POLST, which is different than an advanced directive, which I will get to. The problems that we have with it is how many of us know when, where, how we're going to die? How many of us as physicians, and I know there are only a couple of us in this room, can actually predict how long somebody's going to live? We know from studies that about 50% of the time we're right when we give a prognosis, 50% of the time we're wrong. We have a patient who's on hospice right now who's just madder than hell. He's just so annoyed because he's alive. He was given 2 weeks to live, and it's 6 weeks later. And he got his head around that 2 weeks, and now he's having to get his head around the fact that he's not gone. Now, some of us would say, what a gift. But for him, it's not such a gift. For him, he's just really annoyed about it. What do we expect? How do we interpret? So again, people can't predict what we're having for dinner. And the predictions that we have, that we make when we have advanced care planning, don't always reflect what's going on in real time, medical, emotional, or social context. What's our social context? Okay, so if I'm waiting for a wedding that's going to happen in 6 months, I may make very different decisions about my life than I may make if I don't have that wedding coming in 6 months. Preferences change, and we know this again and again and again in the literature. One of the things when I was doing geriatrics, my geriatric fellowship, I learned very early on is that we don't know how we're going to react to disability. We think about it, and we think about it, I use the example of people who become paraplegic who might have before that said, if I'm paraplegic, I don't want to live that way. Well, many of us know people who become paraplegic and they change their lives and they actually have incredible quality of life. I would say to you that as we get older, we know that the biggest thing that we have going for us is if we can adapt well to some of that disability. But we don't know how we're going to do it. I don't know how I'm going to adapt to it at this point in my life. Value statements. So, we have these value statements that we teach and say you should write them down and think about them and what do they mean. So, wanting to maintain dignity. Well, what does that mean? We know that dignity for one person is very different than dignity from another person. So when I have somebody who says that to me, I'll say, well, tell me a little bit more. What does dignity mean to you? And that may change also over time. Dignity right now for me may be very different than what dignity is 5 years from now for me, depending on my situation. Irreversible, terminal. In this modern world, I don't know what terminal means anymore. Okay? There are so many of us who are living with chronic disease. At what point does it become terminal? Joanne Lynn is a geriatrician and a palliative care doc, and she has a great slide about how we die now in America. And it used to be we'd go along like this and then there'd be a sharp drop-off. Now it's this wavy kind of thing where we're here and then down and then up and down and up and down. At which point on that down is that person going to die? Before I came here, I had to do what's called a face-to-face, which is one of the silliest hospice regulations I've ever known. But I had to do this on a 96-year-old woman who had been on hospice for over 6 months, and she was doing great. She was on for coronary artery disease. She was doing great, and I had to take her off hospice because she was doing so well because of the regulations. 2 weeks later, in the middle of the night, she has an acute MI and ends up in the hospital, which is absolutely where she didn't want to be. So I had to go see her again in the hospital to do another face-to-face, say, yes, she should come back on hospice. I will not take her off, but I don't know really if she's terminal. I don't know how long she has. I know she's 96 and has really bad heart disease, but I don't know. And what is really no hope? I think Janine talked a little bit about reframing hope, and I do that a lot with my patients, because no hope, what does that really mean to you? Again, what does that mean to the individual person? We talked about chronic disease. there may be somebody, for example, who has stage 4 cancer of whatever, but they come in with an acute heart attack. They may want to change their decision. They may want to be intubated for that particular situation, not necessarily for their cancer. I can tell you right off the top that their prognosis is still very limited, but in terms of their heart failure, they want to be treated for that. So what are the problems with surrogate decision makers? Because some people say, well, let me just tell somebody who should be my surrogate decision maker. Everybody knows what a surrogate decision maker is. Okay. Sometimes surrogates don't know that they've been chosen. Okay. I write down my son. Well, he may not know that I've picked him to be my decision maker. Or I may have picked him, but he may not have ever had any conversation with me about end of life. Well, that's not going to be true with my children because I've been doing it for so long and they know. But, many people don't have those conversations. There's a lot of stress and anxiety, and there's a lot of times, I have this not uncommonly, when families and patients get to the hospital and the family says, I don't care what the advance directive says. I don't care if you have a signed POLST form. This is what I want for this particular moment at this particular time. And you know what? That trumps everything. And what we do in that situation and what EMS does in those situations when they have something that's conflicting, we say, get them to the hospital, we'll sort it out in the hospital. And so we get palliative care involved. That should not be, you shouldn't just, well, they have this document. We've got to go with this document. That you can't do it that way. So there are some guidelines. First of all, you've got to make this, as I've said, highly individual. And one of the things that they teach, they do this great thing that I'll be talking about in a little bit in La Crosse, Wisconsin, which really isn't so much what are your decisions. Do you want to be on a machine? Do you want to have CPR? But what really are your values, and what do you want to communicate to your surrogates that are important? Okay. So we're looking at a new objective, which is really to prepare for in-the-moment decision making. Okay, and that shifts away from asking patients to make premature treatment decisions. If I drop dead right now, please resuscitate me. But 5 years from now, I may not want that. Okay. And if you resuscitate me and it's not successful, my family does know what to do. But right now, that's what I want. And when my father was dying, he was 68 and he was dying in the hospital, they did resuscitate him, even though we knew he had no chance. You've got to work with what's going on at that particular time. So you've got to look at the clinical context and you've got to look at goals. I spent a lot of time talking with patients about not their hopes even, but what is your goal? I do this a lot with persistent pain patients. I talk to them, what's your goal? Where do you want to be functionally? Where do you want to get to? And the advance directive is just one piece of that information. Okay, what is their function? Where are they going? What would be acceptable to them? And what matters most to patients? Matters most to them is not the treatment, because they don't really know what the treatment is, but what's the outcome of that treatment? So one of the problems that I run into is if patients have had CPR in the past, they say, well, I did great with CPR in the past. Why wouldn't I do it again? Or my wife had CPR 20 years ago and she did just fine. So why would I not want that now? So you've got to go back to what is the clinical context and where are they in their own trajectory of their life. You cannot do it just by saying, do you want CPR or not? Because it doesn't mean anything to them. I had one patient recently who didn't want to go to surgery. And when I and it was probably appropriate that he didn't want to go to surgery, although the surgeons thought that they could actually really treat this. He was 85 years old and he had tumor that was secreting insulin that was in his lungs. And the surgeons thought they could really get this and get his life better. And he was very clear about not wanting to go. And the reason he didn't want to go is his wife had surgery and she died on the table. Okay. If I didn't have that piece of information, I wouldn't have been able to have the conversation with him that I did. He ultimately did not go to surgery. He decided not to go to surgery, which was probably okay. But I had to at least find out that that's what was guiding his decision, not that this was something that needed to be taken out. Had nothing to do, really, with his disease. I want to talk about where people know information about CPR. Where do people get information about CPR? And the TV. And what do you see on TV? And they've actually done this study. They've looked at the success rate of people who get CPR on all these different medical shows on TV. Success rate is about 75%. In addition, not only is it 75%, but either that day or the next day they walk out of the hospital. We know that it's very different, and actually for most of the people that we're dealing with in geriatrics, and there's good data about this, most of the people in nursing homes, assisted livings, their success rate is more, we're looking at about 1%. Okay? So it's much, much less, but we've got to make sure that people understand that. The other thing that's really key on this slide is after Terry Schiavo, there were a lot of advanced directive Tupperware parties, basically, living will parties. And at those things, 61% of them actually clarified what their goals of care were. 66% actually said, I'm going to even let my family know about this because this would be a good idea so that they really understand what's going on. 8% of them spoke to their provider. Okay, so 8% of these people actually bothered to talk to their physician, their nurse practitioner, their PA. So what I tell the providers that I work with is actually, it's up to you to ask them. You've got to ask them about this because they're not going to necessarily bring it up. And we've had studies that have repeated this again and again. Okay. So we also want to help patients reflect on how they're changing and whether they're changing or adapting to their serious illness. That helps people better predict their preferences. As they progress along their disease trajectory, then you can be a little bit more specific. Okay? You can say, in this condition, this is what I know about it. This is what I think is going on. I will never tell my children to not put me in a nursing home. For one, I work in nursing homes. I've been working in nursing homes for over 20 years, so I'm familiar with them. But I also don't want to put that burden on my kids. Okay? If I need to be in a nursing home because of all the things that you guys know, all the things that we heard in the earlier session about caregiver burden, they need to be able to put me in a nursing home. Okay? So there are people who are going to have to make decisions that may conflict with a patient's preferences, and we see that all the time. Often we can't honor their wish to die at home, okay? And often we may need to look at the issue of medical futility that may or may not benefit from transient treatment, okay? Again, these are the people who I see who have, I want to live to my son's graduation. And I may need to go there and do something that I think is medically futile and talk to the family about how even though their advance directive says one thing, we may have to do another. And so we've got to make sure that our surrogate decision makers have that ability, have that leeway to make decisions in real time. It helps. I had a patient in my office yesterday where there's some family conflict going on, which I'm sure none of us have. But these were 3 children, and one of them was insisting on taking his mother back to wherever, and the 2 other brothers had their mother in assisted living, and she was actually doing quite well there. And so they were meeting with me to discuss this. And luckily, they will probably end up going to court, but they did have very clear documents about who was going to make those decisions. And I always counsel my families that if you think there's going to be any kind of conflict whatsoever, make sure you're clear that there is one person who is going to be in charge, one or two people, so that you can have that actual legal power. Okay, so there's no easy way I can tell you this, so I'm sending you to someone who can. In palliative care, this is like, everybody who ever gives a lecture on palliative care uses this slide because we spend so much time talking with families and patients. That's our tool. That's what we do. That is our procedure. So in the moment decision maker, I've talked a bit about this. It prepares the patients and surrogates. It's based on relationships and values, and they reflect, and I can't emphasize this enough, what is the current medical, emotional, and social context? Okay. Again, choose the appropriate surrogate, clarify and articulate values over time, and establish leeway. So there is a program in La Crosse, Wisconsin, Respecting Choices. Who's heard of it? Okay. So Respecting Choices is a program that started out in the 1990s. And what they did in La Crosse, Wisconsin, which is I don't know how big La Crosse is, I always forget, but it's an integrated health system which helped. And what they were looking at was the fact that people were dying a lot in the hospital, and people were dying in ways that they didn't want them to die. And the person himself did not want to die. They were doing a lot of intensive care. They were doing things that families and patients were actually quite uncomfortable with. So they developed this system where everybody coming in not only was asked if they had wanted an advanced care plan, but if they did, then they figured out a way to get it done. I just am throwing this up when we talk about values, when we talk about goals, when we talk about what's meaningful. These are my children and my son's girlfriend, and I would do just about anything for them. And that's what is meaningful to me, and I think that everybody that I ever talk to knows this because I talk about them all the time. But when you start to talk about your own values, your own goals, these are the kind of things to think about. Relationships, okay? So what is the illness experience from the patient and family? We talked about that. Sharing relevant information. So my job as a physician, and your job may be as a provider, as a nurse, is what did you learn in school? What kind of information can you give out? Okay. I can talk to them about, and I do, people ask me all the time, what would you do? What do you think the benefit of doing CPR is? And I give my opinion. Okay. Now, sometimes they don't take my opinion, and that's okay. I had a patient a year ago, a young woman who had cancer, and she was, her story was that she believed in miracles. And she wanted to know from me, did I believe with her? And I said, that's not my job. My job is to support you in whatever your belief is. And I did say to her, my usual line when somebody talks to me about miracles, I say, well, if I would pray for a miracle also, I think that would be wonderful, but if the miracle doesn't happen, then what do we do? And her response to that was, oh no, the miracle will happen. And so I didn't go any further with her. I stayed with her on her level because I would just be banging my head against the wall, and I would have alienated her, and she wouldn't have come back to see me. Ultimately, this person kept seeing me. She then ended up, at the end of her life, in the ICU on machines. We were able to get her off those machines and get her home, and she died with hospice at home. But it was a process. If I had pushed that when I first met her, we wouldn't have gotten anywhere. So yeah, she did spend some time in the ICU on a respirator, but it also gave a chance for her family to really process what was going on. That was an example of negotiation, okay? I negotiated with her and her family, and at the end, the husband, after she died, has been so incredibly grateful to us, and we still get cards from him about what was going on. And then once you've done that, do a comprehensive care plan, okay? And some of that comes out in advanced directives, some of that will come out in POLST, which we'll get to in a minute. So I do want to talk about, back to Gunderson Lutheran, respecting choices. So they started this in 1991, as I said, and began as if asking if the patient had an advanced directive. Now, I was just talking to actually, it's a minister who started this whole thing. His name is Bud Hames, and he now goes all over the world talking about this and has created a similar structure in Australia, of all places. What they're doing now is they have an RN social work MD team, and they're identifying high-risk patients. They're also identifying those patients who are focused on advanced care planning and care coordination. And what I love about this program, so the impact of this program is a positive impact on quality of life, decreased hospitalizations, decreased emergency room visits. But what I particularly love about this program as a primary care doc, as somebody who does geriatrics, is that when somebody comes in, and I don't think they have an age cutoff. In our hospital, we do it at about age 65. If somebody comes in, we ask them if they have an advanced directive, and this is in the office, not in the hospital. We ask them if they have an advanced directive, and if they do, then we'll review it with them. If they don't, we'll say, are you interested in doing this? And we will encourage them to do it, and then we'll say, okay, great. We're going to set you up with an appointment to go talk to somebody who can have these conversations. And that they have trained, skilled people who can talk to them about advanced care planning. And it's just a brilliant job, because I can tell you that, and I'm sure you know this, that as providers, not every physician, nurse practitioner, PA knows how to talk to people about issues around advanced directives. Has anybody had that experience? Yeah. These are the people who come into the hospital who have had multiple illnesses, 85 years old, and they're still full code. Okay? And it's not the full code that bothers me, it's that there's been no dialogue whatsoever. And so you have to start the dialogue in the hospital. That shouldn't be happening. And that's what that's what they're doing at Gunderson. That's not happening. They also have these wonderful promises, which to me, I don't mean to be, I hope that doesn't bother you, I think are really quite wonderful. So the promises that they have made to their patients and to their healthcare system, again, this is an integrated system, is we'll initiate the conversations with patients about their preferences for future medical care. So, do you have an advanced directive? We'll provide assistance with advanced care planning. We'll make such plans as clear as we can. We'll maintain and retrieve these plans. How many of you work in a system where you can't find that advanced directive or POLST? Okay? This is a continuing problem that we have. We will appropriately follow these plans when the patients can no longer participate in their own decision-making. Now, I emphasize appropriately because, again, it's a negotiation. It's not, we're going to follow this plan. They came in with this POLST, and that's what we're going to do. We're going to follow this plan as it is appropriate. Everybody know the definition of palliative care? I put this in here because I think it's really important. I think because palliative care sometimes gets just equated with hospice or end-of-life care. And palliative care is not that. Okay? And this is the Medicare definition of palliative care. Patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. It does it throughout the continuum of illness. It says nothing here about prognosis. It says nothing here about death and dying. And we address the physical, intellectual, emotional, social, and spiritual needs to facilitate patient autonomy, access to information, and choice. Okay? Again, this is not hospice. This is not end-of-life care. This is helping people who have serious illness, helping them deal with their illness. Okay. Talked about this. I spend a lot of time talking with patients after they've seen their regular doctor. And it's not that their regular doctor isn't doing a good job. They don't have those half an hour, hour-long slots that I've created in my schedule where I can really sit down and talk with the patients. And then I go back to the doc and I say, this is what I've learned. I do this a lot with the oncologists. I do this a lot with just the internal medicine docs in my practice. They either don't have time or, and not to their, not as a fault, they don't necessarily have the skills to have this conversation. So palliative care, multiple studies, they've improved quality of life, reduced major depression, reduced aggressiveness, and in some studies, there's one study that we, as we say in the palliative care world, we do the palliative care dance. There was a study where they looked at people with stage 4 cancer, and half of them, they all got regular treatment in terms of whatever chemotherapy they got. Half of them got palliative care, the other half didn't. The people with palliative care lived 2 or 3 months longer. Now, I will tell you that if that were a drug, I'd be paid a lot of money. In my day, people died. Okay, so let's talk about the POLST paradigm. Okay, so POLST, provider orders for life-sustaining treatment. There are a number of different states across the country who now have it. The National POLST site, I would recommend you get on it. There's some great information on it, and I have it at the end of the talk also. I now sit on the National POLST Task Force as a Montana representative, so if you have any issues with the POLST, please come to me. I really do want to know about them. They are different than an advanced care plan, and I'm going to get to that in a minute. It's a medical order. Okay? And the difference between that and Comfort One, everybody knows what Comfort One is? Okay. Comfort One was not transferable. The minute that person left assisted living home or nursing home, they were full code all over again. Okay, deja vu all over again. The POLST goes with that patient from one setting to another. Okay, so it's transportable. That's why I really stress when people do a POLST in our hospital, we make sure it goes with them. We probably make about 5 copies of the POLST in our setting just because I'm so paranoid about it not getting to where it needs to go. So one will go with the patient and the family, one may go in the ambulance with the patient, one goes to medical records and gets scanned into the chart, and the other will go to the doctor's office, just to make sure we know where that document is. Not everybody, yes. Absolutely. And if you get on the Montana POLST site, there's a guideline about filling it out, and it says specifically that you can make copies. Absolutely. I copy it all the time. So not everybody needs a POLST, and I would say that this is, I think, a source of tremendous confusion. It's for people with serious life-limiting illness, terminally ill, advanced frailty, and then there's that others who are interested in defining their care. I gave part of this talk yesterday to my hospice team, and one of the nurses there said, well, I have a POLST, and I want that POLST, and I'm going to keep that POLST. She's young, she doesn't have a serious illness, she doesn't really meet these criteria, but she was darn clear that this is what she wanted. And I have a couple patients like that who are not as young as she is, who just say, I really don't care. This is what I want. I know this is what I want. I'm not going to change my mind. And I want this document that says, do not resuscitate me. So I like to use this question a lot. Would I be surprised if this patient died in the next year? It's the surprise question. And if I'm not surprised, and I talk to the families about this, I say this is the time when we really need to start looking at the POLST. It's a great question and actually has been validated in a number of studies. So, as I said, this is the difference between a POLST versus advanced directive, and I think we get into some confusion about this, okay? People who are really, how do I say this, enthusiastic about advanced directives, and I'm enthusiastic about them, but not overly enthusiastic, say that anyone over the age of 18 should have one. If you're in the military, they have you do an advanced directive before you go overseas. Yes?
Could you tell me what that stands for? I have no idea.
AD?
No,
POLST? Provider Orders for Life-Sustaining Treatment.
thank you.
Okay? So, as I've said, that's for seriously ill, frail, at any age. Because at any age, you may get into problems. It's specific orders for current treatment, as opposed to an advanced directive, which are general instructions, general guidelines for future treatments. Okay? It can be signed by a decision maker. It does not appoint a decision maker, but it can be signed by a decision maker. It doesn't have to be the patient who signs it. Our current form, which I will show you up here, has at the bottom is a physician signature, and on the back of it is the patient's or the surrogate or who's ever making that decision for them, their signature. The advanced directive in our hospital and my clinic setting, we use 5 wishes, and that document, as part of that document, it appoints a decision maker. It says if I can't make decisions for myself, that's who I want to make decisions for me. That's not part of the POLST. Okay. These are just another incredible site, which is the POLST began in the state of Oregon, and it's actually been there for over 10 years at least, and they've actually got some great studies out about it. So this is what it looks like in different states. Okay. Most of them, the original is a particular color. In our state, if you order it from the Department of Public Health and Human Services, it's this lovely green shade. We specifically made sure that this green shade could be copied. And those of you who have made copies know that it is you can copy it, and you can copy it just onto white paper. Okay. Yes?
Is it transferable from state to state?
No, it is not transferable from state to state, but we have a lot of snowbirds.
That's what I'm...
Yes, and I make sure that they take it with them. Now, the state of Arizona does not have a POLST program, nor does the state of Florida, which is where a lot of people go. But the states that do have them, Oregon, West Virginia, Washington, I can't name them all off the top of my head, parts of Iowa, Massachusetts, New York, again, there are a lot of different states. It at least is a very good document for them for the states that don't have it, a good document for them to start working off of. And there are lots of states where this is now in development. Hawaii has it. If you go onto the National POLST site, you can see the map of where the POLST paradigm is. Okay. 36 states have either endorsed or are developing it. So it's becoming standard of practice. It is not transferable, but it's an important document. If I get patients who come in who have the Oregon POLST, and I just redo it on the Montana form. So Oregon is really interesting because they've had it for so long. It comes out of the Oregon Health Sciences place, and they have lots of ability to do research on it, which is something that we're lacking in Montana. You should know that the Montana Task Force, the Montana POLST Coalition, is a great group of people, but we have no money. So that becomes an issue for us in terms of actually getting things done. So one of the studies that came out, they looked at data from Oregon, Wisconsin, and West Virginia, and what they found was that people with POLST were more likely to have orders about life-sustaining treatment and have them followed. These were all nursing home patients, which is really key because this is a very important document for patients in nursing homes. The most recent thing was really interesting. Oregon not only has been doing this for a long time, but they now, out of OHSU, have a registry. So if you have a POLST, it goes into their registry, it gets scanned in, and you can find it from across the state if you plug into their registry. So they have great access, which is one of the issues. Of the people, they had 25,000 people in the first year who actually put their papers into the registry. And one of the things they were able to do is that they could also pull up some people's advanced directives and look at them and see if they were consistent with what they put in their advanced directives. That's a different study than this one. But this study just came out in 2012, and of the people in the POLST program, 86% of them who had the POLST in this registry were over the age of 65, which means we're targeting the right group. We're targeting the people who are seriously ill. 28%, not everybody wanted to be DNR, 28% wanted CPR. Okay? That's their preference. That's the discussion has been had, and at that particular time in their lives, that's what they wanted. 72% had a do not resuscitate order. This was the one that was most interesting. 50% of those people who said they did not want to be resuscitated wanted to go to the hospital. So there's been some people who have said, well, the only reason you have a POLST form is because you just don't want to take care of people. You just want to do comfort care on everybody. Okay. Well, this study actually showed that people did not want to be resuscitated, and they were making that decision based on what was medically appropriate, but they did actually want to go to the hospital in some situations. So the Montana POLST was implemented in 2010. We're still working on it. There are issues about it that I'd be happy to hear about because I know it's coming up in all communities. This is the form. And if you don't have, I think this handout is you can print it out, but the Department of Public Health and Human Services has it. You can also get on the Montana site and print it out. So the first thing is, do you want to be resuscitated or not? Allow a natural death. I like to talk about it in terms of allowing a natural death because that makes it more of a process, value, goal situation than what's, those chest compressions, just those chest compressions. So then this is the treatment options, and this is what I was talking about in the state of Oregon. 50% of the people who did not want to be resuscitated picked the middle box, limited additional interventions. Okay? The first one says comfort measures and says, transfer me to the hospital only if you cannot get me comfortable at home. Okay? But the limited intervention says, I want to be kept comfortable, but I may also want to go to the hospital and be evaluated. I may want IV fluids. I may want a cardiac monitor. I don't want to be intubated. Okay? I don't want to be put on a lot of different machines, but I may want to go to the hospital to be evaluated, and I see lots of people like that. And these are the people that I think are seriously ill, but we don't know where they are in their trajectory. A lot of the people in the nursing home, I'm not sure that's their best option, because I don't think their success rate is that good. But those people who are in the nursing home who are there for rehab, those are the kind of people who probably do want limited interventions. I would say to you that if somebody says they don't want to be resuscitated, but then they go down to the bottom and say, do full treatment, use intubation, advanced airways, I would say that doesn't quite fit. So those are the people I want to have further discussions with. I will tell you that I've had some patients where the facility has given this form to the family, and the form comes back to me, and every single box is checked off. I mean, oh. I don't think that's the best way to do this form. Okay. The back of the form is over here, and actually I think when we redo this in 2013, because we will be reviewing it again in 2013, we're going to change the back of this form. The back of this form is a place where the patient or the surrogate decision maker can sign and date, and that's important information, but I think we're going to move it over to the front of the form. With electronic medical records, these boxes over here are saying that you've reviewed it and there's no change, et cetera, et cetera. I'm not sure how useful those check boxes are anymore. So we're probably going to get rid of that. Okay. So again, this is Section A. Section B we've talked about. I want to talk about Section C, which is about antibiotics. Yes?
I just have a quick question.
Yeah.
Older people that, they're just getting old and getting tired, and, their comment is, well, I'm ready for God to take me anytime.
Mm-hmm.
But then they say, oh, so you don't want to be resuscitated? Well, yeah. You don't want to be intubated? Oh, yeah. So, they're...
So what I do in that situation is I don't start with, do you want to be resuscitated? I start with, let's talk about what that means, okay? And then I also talk to them about what it means to, what the success rate is for somebody like them in terms of actually getting CPR, and that is not particularly successful. And I also talk about the side effects. And when people start hearing what the side effects are of CPR, they say, oh, I had no idea. Again, it's what do you know about CPR? Tell me what you know about it. If I don't go to what they know about it, then I don't get anywhere. And then there are people who will say, I don't care. I want you to do this. I have one patient now who's in the nursing home who's a younger man who's lived with his chronic dialysis, diabetes, congestive heart failure. He was told 2 years ago that he was going to die in a year. He's got an EF of 20%, ejection fraction of 20%. His heart does not work. And he said, do not talk to me about dying. He said, I'm living. I'm going to continue to live right now. And when it's finally my time and I'm on a respirator and you can't get me off, then talk to my friends about it. They'll know what to do. That's where I went with him. Antibiotics. I don't like this section. We'll probably redo it. And the reason I don't like it is because it really depends on the situation in terms of antibiotics. A lot of times with some of my hospice patients, I try to avoid antibiotics because I'm not sure how much benefit they are to them. But if it's the patient's and family's goal, or if they say, I think this is going to help, I will do a trial of antibiotics. So a lot of times what I do in this section, instead of no antibiotics except if needed for comfort or no invasive antibiotics, I'll write in depends on the situation. So I'm not that happy with this section. Because invariably I end up having conversations about why wouldn't you give antibiotics? And I hate it when they come to the emergency room with this kind of form, because the emergency room calls me and says, well, they said no antibiotics. And I'm like, it's a dialogue, it's a conversation, and I have to do that with them. The nutrition, no feeding tube for defined trial period, feeding tube long term. I will tell you the majority of times that I fill this out, most people do not want a feeding tube. But sometimes they will want it for a defined trial period. Those people who have head and neck cancer, they're getting feeding tubes because they need that for their treatment. And then the back section, who was it discussed with, basis for order, contact information. This is a lot of extra information that I'm not sure we really need so much. We do need a physician's signature. So those forms, I actually have an assisted living place now who's doing a little QI on all of the people who have POLSTs to make sure that they actually have physician signatures. How many of you have trouble getting physician signatures? Okay. I can tell you, yes.
Like PAs or
Yes.
commissioners sign them?
Yes. And that's why it's actually not called physician orders, it's called provider orders. The Board of Medical Examiners was very clear they wanted all providers to be able to sign this. Okay.
Can you speak to why the new POLST program has the blood products and the IV fluid option removed?
Yeah, I can actually. The blood products is a conversation that is so individualized that people don't understand it. So we removed the blood products, and actually we were the only state of all the 36 states that had blood products on it. And we discussed it with the National POLST Forum, and they said, I would take it off, and we agreed. IV fluids, again, it's a situational kind of thing. It's sort of like the antibiotics. it sort of depends on the situation. We have people on hospice who get IVs. Okay, so I felt, and the rest of the task force felt, that it was not that helpful and it was a difficult decision that families needed to make about IVs. So that's why we took it off. So the issues that remain in terms of POLST, and again, I would be happy to have you email me about any of these, because we need to be looking at these more consistently. As I said, we have no money, although we did get some money to actually have a retreat for our task force, which is a good thing because we need it so that we can come up with a consistent plan. Signatures, getting physician signatures can be getting provider signatures can be a problem. Yes?
I'm curious to know, my mother lives in Lewistown.
Yes.
Her gerontologist, Dr. Kathryn, is here.
Yes. Yes.
She's the one that went through the POLST form.
Yes.
And signed it.
Yes.
But she doesn't really have privileges in the little hospital in Lewistown.
Yes.
So what is the reasoning for the provider signature? I was assuming it acted as a doctor's order.
It is a doctor's order. So if your mother, so if EMS came to wherever she lives because she had died, I'm not saying that she will, and they see this form, they have a doctor's order that is signed that says they do not have to resuscitate her, or that they can follow comfort measures.
Which they'll never find because she is not about to hang that ugly blue envelope on her door. But my next question, seriously.
No, I understand that. I do. I totally understand that.
All of that, but you want me to hang that on my door or my wall? I don't think so.
Right, right.
So she ends up in the hospital, and I'm asking you this because all of us children live in Montana, but we're in the far west.
Absolutely.
It's going to take us a while to jump in the truck and get
Okay.
there. So meanwhile, the ambulance gets there because the neighbor hasn't seen Rosa.
Right.
She finds her on the floor. The ambulance comes in, does their thing.
Right. So I would say to you,
She's intubated, she's in ICU. The first daughter gets there, finds the blue envelope,
yes.
and takes it to the hospital. Is that just helping them, the attending there at the hospital to go, oh, this is what
Yes, yes it is. And for two, I would say to you, I would take a copy down to the hospital medical records and have them put it in her chart. Okay, so that your sister or whomever doesn't have to come in from 9 hours away, find that document and bring it in. They have it there. The doc hopefully can say to you, I have this document in my hand. Is this how you want us to proceed? Okay, and that's one of the issues that we have, that we run into in the state of Montana, is training. How many providers out there really understand this document? How many hospitals out there really understand this document? And I have talked, not everywhere in the state, but I've talked in a variety of places. One place was up in Kalispell, and one of the nursing homes there, and the next thing I knew, a week later, the nursing director had taken all the POLST out of the chart because she thought that they could then, if they had them in the chart, then they wouldn't do any treatment. And I'm like, that is so much not what I said. So there's a huge education curve that we need to do, that we are working on, but with no resources, it's a little difficult. We're trying to figure it out. So I think consistency in the document is sometimes a problem. I told you about all the check boxes. I told you about somebody who says do not resuscitate, but then, do everything, box. So looking at those and really, when I get those documents, sometimes I think it's because people who have not known what they're doing are filling out. I actually stopped one of the assisted living places that I work with they had the POLST in their admission package. And I think that's okay. I'm uncomfortable with it because it was just being handed to the family, And then what's the follow-up? What's really happening? Where is this document going? And are they taking it back to their provider? I've had patients in assisted living where the signature from the provider is never on it because it never got to the provider. So I'm having them take that out of their admission package. Yes? Okay, so that's further down the line, partly because we don't... I'm sorry? Oh, absolutely. So what we do have is the Attorney General's office has an advanced directive registry where you can send in your advanced directive. It's used a lot in Missoula because that's where it started. I would say the rest of the state probably isn't used at all. The reason I'm hesitant about pushing on for a registry at this point is that there's so much local education that needs to be done right now that I don't want to do that. One, we have no money to do it, but two, I don't want to create a system that's just another system that's not going to be used. So ultimately, yes, I think it would be great, but we have a ways to go. Lottie.
I have a problem if people in nursing homes, they've been in nursing home last year, they come in, they get their polls completed by the efficient person. They go home, they come in this year, and because it's part of the admission packet, they get a new one. And so if there's no, again, it's part of the admission work.
Right.
There's no discussion about with the person about, do you have one, do you have one, has it changed? It's a whole new document.
Right.
And then they go to the hospital, they come back, and they may have it done again.
They have a third document, yes.
And they're all just a little different. And you
Yeah.
talk with the individual and their family, and it's not the same as any of those.
Right, right. So that's another problem, which is, consistency. So the rule of thumb is that the most recent date is the one that you look at, okay? But I will tell you that I have patients, I have families where they say, I show them the POLST, and they may have signed it or may not, it may have been somebody else, and they said, I know nothing about this document. So I'm working in my community to make sure that if the nursing home is going to do it, that it is very clearly explained to the families about what the document is. I think there's nothing wrong with reviewing it and getting a new document. That may be the easiest way to do it, but I think you've got to have that discussion of what's consistent, what isn't. Yes?
If you don't recommend that the polls is in the admission packet, what do you recommend? How do you recommend?
It's a great question. What I recommend and what I have not done is that there be an information sheet about the POLST, an information sheet about advanced care planning. Now, those are available both on the National POLST site and on the our site. And I would recommend, and I'd be happy to, so this is, again, comes back to consistency and how are different places doing the POLST. I know how it's being done in my hospital. I know how it's being done in my settings in Bozeman, but I can tell you, out in Sydney or wherever, I'm sure it's done in a lot of different ways. So that's part of what we're trying to develop in terms of the task force. I just yesterday got onto the Massachusetts, they call theirs the MOLST, and it's molst-ma.org. And their site is really interesting, and they have some great information that I'm hoping to take and get to put on our site, because they have some very specific things about implementation. How should I use this document? How should I implement it in my care setting? And I'm going to take it to our next meeting and say, I think we need to have something like this, because I think there's a lot of confusion about how to do it. The other thing I would say to you is that make sure you identify somebody in your institution who actually has had some training about how to have these conversations. And so that's another thing I've been trying to do. Linda Bierbach has gone around the country, and she and I are meeting next week. She's gone around the state to do some training around respecting choices. That's a labor of love, I think, because it's a big training. But if you can identify somebody in your facility who's going to be that key person to do the POLST, it can be a social worker, it could be a, your MDS coordinator, it could be whomever, then figure out how to get them some training around it. That might be the best way to go about it. Yes?
You mentioned the comfort one not being a part of this because this is the doctor's order. Where does 5 wishes come in?
5 wishes is an advanced directive.
That is advanced.
It's an advanced directive. Yes?
Do they still do the comfort care?
They don't do Comfort One anymore. We are phasing it out, and what I've discovered, because I used to say when we first started getting POLST, well, you don't have to redo the Comfort One. I've now started to, if people have a Comfort One, I'll do a POLST with them just because of the transferability of that form. Because I've run into some problems when people don't have the POLST, but they just have Comfort One. I think I'm just about done. I would say to you, I can't stress this enough, please get feedback to me. I did not put my email up here, but I'd be happy to troubleshoot issues that come up with you. That's part of my job. We are going to try to use some Respecting Choices trainings across the state. These are some other sites that are in your handout. The Gunderson, I don't have on there the Massachusetts site, but I'm going to put that on here because I was so impressed with it. And then just finally, just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me, okay? Okay. Thank you. I think we're probably out of time, but I'd be happy to answer some questions up here or to give out my email.